A young woman, Emily, is on her way to meet Lisa, her best friend, but she got stuck in heavy traffic.
Hi Lisa, I'm sorry for making you wait. Traffic is heavy. How long have you been here?
Hi Emily, I just arrived too. It has been a long time since we met, isn't it?
Yeah, how have you been? You seem to be bothered by something.
I'm doing just fine, Emily.
Why? What's happened? Was everything okay?
It's actually about my dad. He's been dealing with some health problems recently.
Is your father alright? It seems like a serious topic.
Yeah, these past few months, he's been having urinary troubles. He always go to the toilet, especially at night, while during the day, he did feel the need to go, but he only passing small amount of urine. He finally went to see a doctor after I persuaded him a few times.
When did it start? And how frequent was it until you guys sought professional help?
As I remember, the doctor told me this disease usually has 3 stages, just like my father had.
Oh, that sounds tough, but at least he wants to seek professional help at the end. What did the doctor find out?
He was diagnosed with benign prostatic hyperplasia, also known as BPH.
If I'm not mistaken, BPH is an enlarged prostate, right? I have learned that due to the enlargement of the prostate, the gland presses against the bladder and pinches the urethra. Eventually, the bladder may lose its ability to empty completely because of narrowing of the urethra and urinary retention.
At first, he had trouble to urinate and he always took a long time in the toilet because of the weak urine flow. Thus, he experienced intermittent urination. He needed to push the urine out because he was unable to empty his bladder completely, that led to the leaking after urination, until he started to having nocturia and cannot hold his urine anymore, which disturbed his sleep time. Then only he agrees to the further checkup.
Lisa accompanied her father to see the doctor, and he needs to do urinalysis and urine culture tests first.
Oh, I remember studying about this. Urinalysis is an essential diagnostic tool used to detect hematuria, identify urological conditions such as urinary tract infection, UTI, glomerulonephritis, and kidney stones. It detects signs of UTI such as white blood cells, bacteria, nitrites, and leukocyte exteris. It identifies kidney stones through crystals, hematuria, and high mineral levels, and diagnoses glomerulonephritis by finding protein, red blood cell counts, and dysmorphic red blood cells. Urinalysis evaluates kidney function indirectly, assessing glomerular filtration rate through proteinuria and microalbuminuria presence, and monitoring glucose, ketones, and electrolytes. It helps monitor chronic kidney disease by tracking proteinuria and kidney damage markers, detects glucose and ketones for diabetes management, and monitors proteinuria to manage hypertension-related kidney damage. But what did they find out for your father though through this test?
Wow, I feel like I'm in a lecture hall. You are right, Emily. Daddy found red blood cells in his urine and confirmed he suffers with urinary tract infection, also known as UTI. After that, prostate-specific antigen test was conducted on him to know his PSA levels.
Oh, the PSA test? This test is always done in suspicion of prostate cancer and BPH. A higher than normal level indicates enlargement of the prostate.
His PSA levels were indeed higher than normal. To rule out whether it was prostate cancer or BPH, they did a digital rectal examination and found out his prostate was enlarged, non-tender, with nodules and flaky appearance. This examination helped them to rule out that my father is suffering from BPH.
This is a gross examination of a normal prostate, characterized by uniform consistency without nodularity. Whereas in BPH, the prostate was enlarged due to the nodular hyperplasia. In BPH, the prostate undergoes noticeable macroscopic changes, including significant enlargement. This enlargement is characterized by the formation of nodular growths, primarily in the transition zone, giving the prostate a bumpy texture despite an overall smooth surface.
Oh, I almost forgot, Emily. During the last checkup, the doctor asked us to consent to the biopsy on the prostate tissue to confirm it is 100% BPH.
Do you mind telling me what they see under the microscope?
The doctor did explain about the histopathological changes, but he didn't delve in deeper.
I have some pictures from my Dr. Shima's practical lab. Let me enlighten you on how the histopathological changes in the prostate tissue starts. Starting with the basic, this is what the normal tissue of the prostate looks like. The normal histology of the prostate gland is demonstrated with glands and intervening fibromuscular stroma. The fibromuscular stroma is composed of smooth muscle and fibroblasts, aids in secretion expulsion. As you can observe here, these tall columnar cells of the glands are surrounded by a thin myoepithelial cell layer.
It's quite confusing for a first timer looking at this cell. So, this is how it looks under the microscope. Emily, if you don't mind, I would like to know more about what an abnormal prostate cell looks like so I can relate it with my father's condition.
Of course, Lisa, it would be my pleasure. Let me search it, yeah? Oh, here it is. This is the picture of a tissue of benign prostate hyperplasia under the microscope. This picture shows numerous crowded and irregular shapes of glands that indicate an increase in proliferation of glands. In BPH, the proliferation of prostate cells is primarily fueled by hormonal mechanisms, specifically involving testosterone and its derivative dihydrotestosterone, DHT. Within the prostate tissue, testosterone undergoes conversion into DHT facilitated by the enzyme 5-alpha reductase. DHT, possessing higher androgen activity than testosterone, binds with androgen receptor present in the prostate cells, forming hormone receptor complexes. These activated complexes then translocate into the cell nucleus and interact with specific regions of DNA known as androgen response elements, triggering the transcription of genes. This process leads to the production of growth factors and signaling molecules that stimulate cell growth, division, and proliferation. Over time, the increased cell number results in the enlargement of the prostate gland, leading to the characteristic symptoms of BPH. If you can see down here, the normal glands are larger in size but maintain the cell of origin. This enlargement is typically a compensatory mechanism aimed at maintaining the functionality of the gland. Also, enlargement can occur due to the factors like hormonal fluctuations and age-related changes. However, the glandular epithelial cells still produce prostatic fluid and the stromal cells continue to provide structural support. This ensures that despite the enlargement, the gland can still fulfill its role in seminal fluid production and urinary function. If you observe the part here below, there is atrophy of the peripheral zone from compression. This occurs due to compression resulting from the enlargement of the transitional zone. As BPH progresses, the hypoplastic nodules originating from the transitional zone can grow in size, causing mechanical compression on the surrounding peripheral zone.
Yeah, that's fascinating. Are there more pictures, Emily? I would like to learn more about this.
Yes, there is. In this picture, you can clearly see the glands of the prostate undergoing hyperplasia. Do you know what hyperplasia is? Hyperplasia is an increase in the number of cells. So, in this picture, the gland undergoes glandular hyperplasia accompanied by hypertrophy of the intervening fibromuscular stroma of the gland. As I have mentioned beforehand, the hormone testosterone plays a role in the hyperplasia and the same goes to the hypertrophy of fibromuscular stroma. DHT stimulation also affects the fibromuscular stroma surrounding the glandular tissue. Androgens influence the growth and maintenance of smooth muscle and connective tissue components in the prostate stroma. As a result, the fibromuscular stroma undergoes hypertrophy or an increase in size and mass in response to androgen stimulation. As you can observe here, the irregularity of epithelial cells that line the glandular structure indicates the epithelial cells undergo hyperplasia. The glands appear closely packed, contributing to the glandular hyperplasia. To kind of summarize this, the combined effects of glandular hyperplasia and stromal hypertrophy contribute to the overall enlargement of the prostate gland observed in BPH. The increased size of the glandular tissue and surrounding stroma leads to compression of the urethra, resulting in obstructive urinary symptoms such as hesitancy, poor urinary stream, and urinary retention. This here is the corpora amylosia. Corpora amylosia is a large rounded structure with a central dense area, also known as laminated concretions. Corpora amylosia plays a role in the pathogenesis of the condition through several mechanisms. Firstly, They can obstruct prostatic ducts, impeding the drainage of prostatic secretions and potentially leading to the formation of cysts and inflammatory changes within the gland. Additionally, corporal amnesia induce an inflammatory response in the prostatic stroma, contributing to tissue remodeling and fibrosis.
Oh, wow. This keeps getting interesting, Emily. Are there more?
If we look at a higher magnification, we can observe that the epithelium cells of the glands are thrown into papillary folds as they undergo hyperplasia. Papillary folding in BPH involves the formation of finger-like projections or papillae within the prostate gland. This process is driven by increased proliferation of both epithelial and stromal cells, primarily stimulated by hormonal influences such as dihydrotestosterone. As cells proliferate, they form clusters or buds that extend into the glandular lumens, creating papillary structures. The stromal component comprising fibroblasts, smooth muscle cells, and extracellular matrix provides structural support for the papillae, while vascularization supplies nutrients and oxygen to the growing cells. Overall, papillary folding is a result of complex cellular interactions and hormonal regulation, leading to the characteristic architectural changes in BPH.
Now, I clearly understand the histopathological terms and it makes sense on how it is related to the clinical symptoms.
Apart from this, what about the etiology of the BPH? Did the doctor explain about it?
Yes, he did. The doctor said it is related to hormonal imbalance as men get older. I couldn't quite understand it, but I did some research in order to understand the root cause of my father's disease. It starts from how hormonal imbalance can significantly impact tissue and how it develops, as androgens play a crucial role in the growth and the maintenance of the prostate gland. Testosterone is converted to DHT is increased within the prostate tissue by the enzyme 5-alpha reductase. DHT then binds to androgen receptor in the prostate, stimulating the growth and proliferation of prostatic epithelial and stromal cells since the estrogen and androgen receptor dependent reproduction has been initiated. Increased levels of DHT or increased sensitivity of the prostate tissue to androgens can actually lead to excessive growth and hyperplasia of the prostate gland and contributing to BPH development. Inflammation and immune dysregulation such as bacterial infection, diet, urine reflux, autoimmune response or combination also can cause BPH.
In cases like inflammation and immune dysregulation, it starts with the proliferation of immunocompetent cells, including lymphocytes, macrophages, and granulocytes, resulting in prostate inflammation. This inflammation triggers tissue injury and the release of inflammatory cytokines, leading to chronic tissue remodeling. As a result, hyperproliferation programs are initiated due to increased growth factors and decreased apoptosis. This process causes stromal proliferation and transdifferentiation, eventually leading to bladder outlet obstruction from the mass effect, a hallmark of BPH. But then, there is another prominent etiology of BPH also.
Is that the metabolic derangement such as dyslipidemia, hyperglycemia, and hyperinsulinemia can also trigger BPH?
Yes, you're right. In this etiology, the pathogenesis can be started by decreased vascular supply to prostate areas, causing oxidative stress that could lead to prostate inflammation due to metabolic syndrome. At the same time, metabolic syndrome also causes an increase in sympathetic nervous system activity, leads to stimulation of alpha-1 adrenergic receptors, beta-3 adrenergic receptors, and muscarinic receptors that increase tone and detrusor muscle overactivity. How about the treatment options, Lisa?
The doctor mentioned treatments like medications such as alpha blockers, 5-alpha reductase inhibitors, or a combination of both to relax the prostate muscles or surgery if necessary. There are also minimally invasive disease management such as prostate lift or water vapor therapy. But in my dad's case, since he is in the severe stage of BPH, the doctor suggested to do transurethral resection of the prostate, also known as TURP. Thanks, Emily. That means a lot. I'm glad to have friends who understand and can help me make sense of all these medications.